Diabetes and pregnancy. Pregnancy can both worsen pre-existing diabetes and trigger new diabetes. Poor glycemic control increase congenital malformation, miscarriage, maternal and perinatal mortality. Tight glycemic control before and during pregnancy improved outcome. Gestational diabetes typically develop in the second trimester and may resolve postpartum but carries a high future T2DDM risk. Types of diabetes pregnancy. Pre-gestational diabetes type 1 or 2 diagnosed before pregnancy. Gestational diabetes mellitus diagnosed during pregnancy typical 24 to 28 weeks. Pre-pregnancy management. Glycemic control. Aim for HbA1c less than 6.5%, ideally less than 6.1%. Folic acid 5 mg daily. Stop teratogens, ACE inhibitors. Complication screen. Retinopathy, nephropathy. Thyroid function. Contraception until control is optimal. Education and contact glucose monitoring, insulin use supporting. The stillbirth risk relative increase 4.7x. Neonatal death 2.6x. Congenital anomaly 2x. Congenital defect CHD, spina bifida, anencephaly, microencephaly, increased risk of macrosomia, miscarriaging, polyhydramnios. Glucose monitoring target in pregnancy. Fasting 3.5 to 5.5 millimole per liter. Pre-meal 4 to 6 millimole per liter. 1 hour post meal less than 8 millimole per liter. 2 hour post meal 7 mole per liter. Gestational diabetes. Screen at 24 to 28 week in at-risk women. Risk factor BMI more than 35 kilogram per meter square. Age more than 35. Ethnic monitor South Asian, Afro-Caribbean. Family history of diabetes. PCOS, steroids, stillbirth history. Oral glucose tolerance cyst. Management of GDM. Initial diet, exercise in uncontrolled, metformin, glibenclamide. Insulin is often needed. Insulin OHAS usual stopped. 6 weeks postpartum glucose test. Annual diabetes screening. HbA1c useful in first trimester. Retinal exam at booking as needed. Scan, dating scan 11 to 14 weeks. Anomaly scan at 20 weeks. Fetal growth third trimester. Clinical visit to obstetrician or diabetes team. When to avoid pregnancy. HbA1c more than 10%. Uncontrolled complication. Nephropathy. Proliferative retinopathy. What is the optimal preconception HbA1c target in diabetic woman? Less than 7.5, less than 6.5, less than 6.1, less than 8, less than 6.1. Which of the following is not a recommended preconception step in women with diabetes? Start folic acid 5 mg. Continue ACE inhibitor. Retina screening. Stop stay. What is the diagnostic test for gestational diabetes? Random blood sugar, fasting insulin, oral glucose tolerance test, HbA1c. Which of the following is recognized fetal complication in poorly controlled diabetic pregnancy? Microcephaly, neonatal hypoglycemia, cardiac anomalies, all of the above. Most women with gestational diabetes require long-term insulin after delivery. Women with gestational diabetes are at higher risk of developing type 2 diabetes later. Pregnancy is considered diabetogenic due to hormonal insulin resistance. HbA1c is a reliable measure of control in all stages of pregnancy.